Welcome to the Pot of Inquiry, everyone. This is the podcast for human optimization and understanding. And I'm so honored to have Dr. Jason Williams with us today and discuss really some very incredibly innovative things that he has been doing and continues to do in the treatment of cancer. So, Dr. Williams, thanks for joining us.
Thank you. Thank you for having me. It's good talking with you.
Yeah. So, you've made some chapters available to everyone out there on Spotify, and I'm going to encourage everyone at the end of the episode to go visit those. But I think the first chapter where you talk about how your passion developed for this work is really important, because I think that gives a lot of foundation into why you're able to do what you're doing today.
Yeah.
So,
Yeah. Yeah, it's true. I mean, basically, I think the big thing that I saw was that, why patients with cancer, why were we not addressing putting something into the tumor, injecting drugs into the tumor, ablating it, doing whatever we can, but attacking the tumor directly, when most treatments were intravenous therapies or oral therapies or other stuff, but not getting to the tumor. And so it just didn't really make sense. And clearly, when I did, research in college and we were injecting tumors in animals, we saw good results. And then when those studies carried on into humans, if they gave them intravenous or oral, they didn't work. And so, that was my question, like, why are we not injecting in the tumor?
right.
When I was younger, of course, like some of the doctors I've asked them, I said, hey, why are we not injecting in the tumor? They said, oh, well, it's just too difficult. And
Right.
so I thought maybe okay, but then when I went to medical school, and I was in a lecture for interventional radiology, and interventional radiologist was explaining what they do, and one of the things is that they biopsy tumors and they stick needles in tumors using imaging, so you can see
Right.
obviously, one of the ways we look at cancer is imaging, and you can use that same imaging to place needles into tumors and biopsy them. That's how we make the diagnoses anyway. And so then when I saw that, I was like, wait a minute, if we're getting needles into tumors, then we should be able to inject medications into them. We should be able to treat right then. And that's kind of what led me in that direction. I knew I wanted to be in cancer, but, I gravitated more towards the radiology side because I felt that gave me the skills that I
Right.
needed to do what I wanted to do. And I heavily focus, on immunology, immunotherapy. That's my big, research on that. We develop lots of cancer drugs. We develop lots of immunotherapy drugs, and so we inject these in the tumors. And then the interesting thing is, obviously, one is that you can inject lots of drugs in tumors. It's a little more forgiving because
Right.
you're giving lower doses, small amounts, but also, when you're trying to get the immune system, you want the immune system to attack in the cancer. You don't want to like just shoot the stuff everywhere in the body and go all over the place. You want it to be targeted there. So that's
So
what I found.
let me ask you, because you described. So I want to make it clear to the audience, and correct me if I'm wrong, but you're really the first individual pioneer that has done ablation for intratumoral therapy, and
Yeah.
so I recall in your chapter you talked about a patient that had four lesions in his lung, or two in each side, but you felt it would be too overwhelming for the patient to undergo ablation of all four lesions. And I can't remember if that was cryo or radio
That was
frequency
radio
ablation.
frequency at that
Okay.
time. Yeah,
Okay.
though we were doing some cryo. We saw it in both situations,
Yeah.
occasionally.
So with that patient, uh, you saw you treated him, and then you came back several weeks later, and the other side that you didn't treat, those lesions were gone.
Exactly. Yeah.
So
Yeah.
what was that, like one of the light bulbs that was going off?
Definitely. Definitely.
Yeah.
Obviously at that time, thoughts were not really like you're going to stick needles and inject drugs, or you're going to do things. You're going to, stick a needle and you're going to ablate it. You're going to destroy a tumor. So there's tumors and we're like, oh, we can just pick them off.
Right.
And so that's what we were looking at. But what we were seeing was that, in certain circumstances, when we killed the tumor, we generated an immune response
Mhm.
against the cancer. And then not only the cancer that we treated responded, but occasionally the other lesions that were not touched responded. And though the way that technique is done, it's rare. We were lucky that we saw it, in
Right.
such few cases, because it's definitely been reported in the literature. I mean, I think there's some studies going back in the 60s where they were freezing some tumors in prostate cancers, and they were seeing responses in bone metastasis and things like that. That was been described. They call it the abscopal effect, the distant effect, off target effect.
Right.
Uh, but yeah, we were seeing it, and then that was the part where I was like, gosh, okay, if we can do this, how do we make it better? What are the ways to
Right.
improve this? And that's, definitely led to an evolution of both the technology of ablation and, of course, also adding medications into the mix as well. And so, you have all your typical ablative technologies, like people do microwave and they do radio frequency and they do cryo. Now you have pulse electric field is a newer technology. When you look at it, the pulse electric field seems to be more the superior for immune stimulation.
Right.
Cryoablation can be, but needs to be done in certain ways, so it's a little more operator dependent. And radio frequency and microwave are immune stimulating, but very minimal, and most of it because you're just blasting through a lesion, and you're not really like leaving the pieces there to stimulate the immune response. So they're not as immune stimulating. We were lucky that we saw it, but I did my ablations in kind of unusual ways because I was doing like these partial ablations, and that actually turned out to be more immune stimulating than ablating the whole tumor. That's
So was the immune response the primary factor in your evolution, going from cryo to radio frequency, or radio frequency and cryo, then and then getting into the pulsed electric field?
Yeah. Then at that point, everything was kind of chasing what's going to get the better immune response in the cancers, and how can we do this, killing cancer, but do it in a way that also makes the immune system want to attack it. And so, what can we do to enhance that? And that's the things that we were, trying to figure out. And, the technology evolved. I mean, pulse electric field has only had FDA approval for about 2.5 years.
Okay.
So we didn't have that weapon before, as I think it was discovered in the 90s. To explain the difference of it, it's a technique where you're essentially shocking the cancer, but so fast, like such that it looks like nothing happens, right?
Right.
It's like the time frame is, a millionth of a second, but electrical. Wow. And then so the membranes open up and the cells die like in a certain way that seems to be more immune stimulating, because you're leaving more of those pieces that the immune system can see. Cryoablation also does that. So, it leaves like the pieces intact,
right?
Because you freeze it. But cryoablation, one thing it'll do is that it can damage some of the tissues around it. And then that can cause healing growth factors, and that can negate some of the immune response. So that's why cryoablation is challenging. I mean, it will work, but you have to do it in the right way if you're looking for pure immune stimulation.
So I think that's an important distinction that needs to be made, because I think a lot of people are thinking, wow, I've got this tumor and you guys are eradicating that tumor. And that's really not the case with the PEF treatment. It's a treatment that is probably eradicating some of it, but leaving it behind to create the immune response that you want, correct?
That is correct. And this is the thing that I think really messes with everybody. They have a hard time wrapping their head around this.
Yeah.
Because what they want to see is that you go in, they want you to destroy all the tumor. You're in there, kill the whole thing, right?
Right.
That actually ends up being not the best thing to do. And we actually, a study that I supported that came out of Case Western from Alex Huang, is published about 2 years ago, that I think really demonstrated the mechanism behind this. Okay. We did cryoablation, and we found if we ablated the entire tumor, there was no immune response. But you ablate part of the tumor, and there was an immune response. And interesting enough, the immune response was because the tumor you ablated part of it, the tumor that you left behind began producing immune stimulating substances itself.
Oh, wow.
Yeah, but
Yeah.
particularly something called stimulating interferon genes. So the tumor was actually doing that. That's why you had to leave some behind, and
Okay.
that really, I mean, that was published, and I don't think anybody really still catches on to that full concept. But the idea is that really, to get an immune response, you just want to create some damage, but you don't want to go and just blast everything.
That's a very interesting concept. But the other thing I think I gleaned from what you've been talking about is that these tumors initially are they're isolated. They're pretty walled off, for lack of a better way of putting it. And the PEF treatment seems to make that a little bit more penetratable or
It definitely
for,
attracts
yeah.
the immune response. So all the studies we see with pulse field is that, you know, when you kill tumor that way, you start getting a lot more immune cells being able to come into that site.
Is that because the wall is kind of like fenestrated?
That's it's a good question. I think there's multiple factors to it. I think you're killing and allowing some of those pieces that would then travel to nodes
Okay.
nearby, activating them.
Okay.
They're it's an interesting way of how those cancers die. That stimulates the immune response more. I mean, there's things that things can die in certain ways that attract the immune system, or things that can die in certain ways that don't attract the immune system, or cause repair. If it causes repair, that could be actually detrimental, right? The immune
Right.
system repairs and out assisting the cancer. You don't want that. So, yeah, the
So
pulse field does a really good job overall.
so does the cryotherapy maybe cause a little bit more fibrosis, which is detrimental than,
Well,
or is
the
that
the problem with cryo is, one, you just got, you can kill like a small area. You don't want to get overzealous, and you do not want to damage normal tissue. But what do most doctors, when they do cryoablation, they approach this as a surgery, and what do they want? Their margins.
right?
So they say, we're going to freeze the tumor, and we're going to get normal tissue margins.
Gotcha.
Well, you can do that, but you're going to now start getting healing growth factors, and so you suppress the immune response. And
Okay.
so your cryoablation went from what could be immune stimulating to now immune suppressive.
So
And
the whole premise is that the people that are coming to you, they have to reframe their mindset
yeah,
into, it's like, hey, we're not getting all this tumor out, but
but we're going to get your immune system to see it. That's
exactly.
that's the thing. So it's a better situation, because like it's like, if we go and get too aggressive and try to kill it all, yeah, we do a good job. We can kill it all, but I mean, there might be some. Then the stray cells and other stuff is going to be around, but your immune system actually now going to be less likely to attack the cancer. You have to target these in a way that does it where the immune system wants to attack the cancer.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine,
You're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that STEM Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of STEM Regen. Hey Spelunkers, we're thrilled to kick off Season 6 with a fresh new look and the most exciting content we've ever delivered. This season, we're diving deep into the fascinating world of human optimization and understanding. But wait, there's more. We're giving back to our loyal listeners with an exclusive giveaway each and every episode of Season 6. That's right, prizes are waiting just for you. So how can you join in on this fun? Well, it's simple. Follow us on Facebook, Instagram, and LinkedIn. Subscribe to our YouTube channel, and here's the magic touch. Comment, "Let's Spelunk" on any of our Season 6 YouTube videos to enter. Of course, please add anything else you'd like to your review. Don't miss your chance to explore, learn, and win with the Pod of Inquiry. Let's spelunk into the wonders of Season 6 together. So you talk about the tertiary lymphoid structures.
Yeah, exactly.
Yeah. So can you explain what that is and how important that is in the whole process?
Yeah, so it's something that they started identifying several years back with immunotherapies, that these were things that look like lymph nodes but aren't really official lymph nodes.
Okay.
But the immune cells are grouping around close to the cancer, wanting to attack it, and so that's what they call a tertiary lymphoid structure. Most of them have a lot of B cells in them, and so pulse electric field ablation is associated with creation of these tertiary lymphoid structures.
Okay.
That's so you do pulse field ablation, and you see development of tertiary lymphoid structures. So you know that it's ablating in a way that's immune stimulating.
But you don't see that so much with the other ablation techniques.
You don't. Yeah. I mean, you could. I mean, so in the right hands. I mean, I can make cryo work, right? I could
Right.
do cryo. I could make any of them work a little bit. In my opinion, pulse field is my choice. Pulse electric field, but when I do cryo, cryo would be a situation where, let's say, you've got a patient and you've stimulated an immune response. Let's say an early stage breast cancer. You stimulate a little bit of immune response first, and you get it going, but you don't want to give this patient a ton of treatments. You don't want it to be drawn out. You want to try to get this cancer fast. So first you get the immune response going, then you wait a few weeks, and then you come behind and you just freeze it and get rid of it.
Okay.
But you would be better to stimulate the immune response against it first, and then come behind and then get rid of it by freezing it all, so that you've gained that immune stimulation first, and then later you get rid of the cancer.
So after you use the PEF, and you're talking about also introduction of different agents intratumorally
Right.
to help enhance the immune response, correct?
That's
And I saw somewhere where you were discussing with Dr. Goodyear about not IV vitamin C, but intratumoral vitamin C.
Yeah, vitamin C.
Yeah,
Exactly.
yeah. So give us a little take on that and some of the other things that you're putting in after you destroy, or not destroy, but start this process.
A lot of times, a thing is there's lots of things you can inject in the cancer to kind of help boost, the immune responses. Right. And certainly, vitamin C, ivermectin, things like that can be very useful to inject in the tumor. We have them in injectable forms, so it's easy. They're inexpensive. So sometimes it's we're in there, the immunotherapy drugs are super expensive, right? Mm-hmm. So if we can just kind of boost that and make it a little better with some other drugs that are cheaper and add to it, then, we reduce the cost. That's what we're trying. What we're trying to do is not have to do all the heavy lifting with big time drugs, like all your checkpoint inhibitors and things like that. I mean, you got,
Right.
Yervoy, Opdivo, Opdualag, all these other drugs. Those drugs are mostly monoclonal antibodies. They're a lot more expensive. And so what we're trying to do is use some of these other agents that are less expensive but can get things moving so that we don't have to use as much of the expensive agents.
Well, aside from expense, what about adverse events? I would
Well,
think
that's true. You reduce adverse events, right? Because as you're using these more harsher agents that are heavily T cell focused, you're going to get more autoimmunity. You're going to get more problems with that. So you do want to reduce the amount that you need to do. I mean, I know you have to kind of tailor these cases. I mean, a little depends on what the situation for the patient is.
right.
In some patients, you got to push somewhat of a T cell response, and that's going to be more aggressive. Other patients, you can push more of what we call a myeloid response, so getting more of the macrophages and things like that. That would be a milder, slower. You're not going to get, these autoimmune issues and things like that you would see with, those other treatments.
So one of the things that impressed me so much about what you guys are doing is that these treatments are minimally invasive, and I hate to say it this way, but they seem much more minimally disruptive to a person's life, and they're going through a real tough time to begin with, and now you have a lobectomy or some kind of major surgery, and then you're on chemo.
Yeah,
you almost have to question: is it really worth going through all that?
We should not be operating on these people.
Yeah.
I mean, I think in the future will show that for cancer patients, you should not operate on them. What you should do is a patient who has a potential suspicious lesion, you'd say, okay, you shouldn't even biopsy it at that point, right? Like don't mess with it first unless you're going to start treating it. So you say, okay, here's a lesion. It looks suspicious. Look, we know on imaging, we know, however we're looking, this is probably cancer, right? So it might as well be our first time that we're going to address the lesion with a needle. To sample it, we should be treating. We should be putting something in it. I mean, even if it's, ivermectin, vitamin C, ketorolac, you can inject the flu vaccine into it. You can inject like various things, like get, anything to get, like the immune response going into that, but not just like poke it and leave it alone, take something out and inflame it, make it mad, and then wait several weeks for results. And then say, well, now we're going to come back and we're going to try to treat, and you've stirred it up. And so in the future, we should not be doing that. We should be treating them right from the start.
So that's a really important point, because usually when people find a mass, the first thing is they're terrified, and it's like, oh man, I got to get this thing cut out right away. And that paradigm's got to change based on what you guys have figured out.
It does. I mean, it does. It basically, it's like you should not disturb it, and they're starting to figure this out a little bit on the mainstream. I mean, obviously we're trying to push this. We want everybody doing this. It's not just us. I mean, this should be standard of care. That if you're going to biopsy, you should be injecting something in it. I mean, that should be standard of care. But you see now, like prostate cancers. Prostates before, they're like, oh, PSA gets a little bit high, they want biopsy it, and then they say, oh, that's too aggressive. So now they're saying, wait, let the PSA get to 20 before you start, because when you start messing with it, things go downhill, right? And that's what we see. And so if you're gonna mess with it, if you're gonna start sticking something in it, you better be ready to like go ahead and try to treat and take care of it. But we don't need to be like aggressively cut these things out and all the chemotherapy, all this stuff. That's going to end up going away. I mean, it's going to be where you just identify it, and you're going to gently then go ahead and get the immune system to attack that cancer, and it'll be easier that way. Because where we're treating patients is they've already been chemoed and everything else, and their immune system's all messed up, and then now they're coming to us treatment. Whereas if we had them from the start, it'd be way easier.
No, that's a very important point. But the problem is that you get these dogmatic paradigms that they've just been ingrained. I mean, a great example is saturated fat. That's the horrible demon. Don't go low fat and high carb, and but that's been inculcated for decades. So it's hard for people to say, okay, I gotta change my shift my paradigm here, because that's not what's happening. So you talk about some big hurdles that you had to go through when you were going through your research process and getting your facilities started. Was it mostly, what was the pushback from insurance, or was it pushback from other oncology experts? What was the...
A little all of it, probably.
Yeah.
I mean, there was various things. I mean, one, obviously, is a lot of stuff that we're trying to do. There was no insurance coverage for, and still even today, a lot of stuff we do is not insurance coverage for. And that's, why, we do a lot of our stuff outside the country because it's cheaper. But we do have clinical trials, in the United States as well. Right. So now we're trying to get that as approved and get this as official. So as those things are developing, but yeah, originally, certainly, cost, insurance, oncologists, not, everybody's like, no, it's like great. It surprised me. Oncologists, say, oh, well, that's crazy. Like, why are you going to put medication in the tumor? That just makes no sense. I'm thinking, I don't know. That seems to make sense.
Yeah.
But yeah, and they were just like, everybody was kind of against me. But as we started building and showing more results, and then, as we got more now we have formal clinical trials. We've already done, some nice clinical trials, and we've got a phase 2 trial in the United States going on right now. So we're establishing that under the official record, and now people, oh, okay, yeah, this does
right.
Look like it's good.
Well, you have to let your results speak for themselves, because it just takes a long time. I mean, It's just one of those things where you're fighting it. Now, one of the other things that really impressed me with what you all are doing is you're optimizing the human in addition to these treatments. So you want to talk a little bit about the gut microbiome, how important that is, because I think that's really important.
And now a message from our sponsor. The power of ketones, your body's alternative fuel. The folks at Approved Medical Solutions have done it again. That's right, with their new Clean Ketones supplement. Imagine your body as a hybrid car capable of running on 2 different fuel sources. While glucose is your body's regular gasoline, ketones are like switching to an efficient, clean-burning alternative fuel. I would say rocket fuel. When your body produces ketones, whether through fasting, low-carb dieting, or intense exercise, something remarkable happens. These molecular powerhouses cross the blood-brain barrier, providing crystal-clear mental energy that many describe as enhanced focus and clarity. But ketones aren't just brain fuel. They're efficient energy sources for your heart, muscles, and other vital organs. Think of them as premium-grade fuel that produces less metabolic waste than glucose processing. Research suggests ketones may offer additional benefits: reduced inflammation, improved metabolic health, and even potential neuroprotective properties. They're particularly interesting for athletes seeking sustained energy and anyone looking to optimize their cognitive performance. The best part? Your body is naturally designed to produce and use ketones. It's not about completely replacing glucose, it's about metabolic flexibility, giving your body the ability to thrive on both fuel sources. Whether you're interested in mental clarity, athletic performance, or overall health, understanding and harnessing the power of ketones might be your key to unlocking new levels of well-being. Approved Medical Solutions Clean Ketone Formula contains nature-identical ketones. These ketones provide the same fuel as those produced through a keto diet. Approved Medical Solutions Ketone Formula does not contain sugar, caffeine, or 1,3-butane-diol, and they are not ketone salts. I've been using them routinely now and notice a minimum of a 10% increase in exercise performance. By diving deep into cutting-edge research and real-world applications with leading scientists and practitioners, the Pot of Inquiry illuminates the science-backed path to enhancing your mind and body's potential. You can find us on all platforms, including Spotify and Apple Podcasts. Please join us.
there's a lot of interesting stuff. So the thing that I thought was interesting is that as we started really getting good with immunotherapies and things like that, we started finding out that we were making the patients healthier,
Mm,
not
right.
sicker, which normally you'd expect to make them sicker. And obviously,
Right.
there can be some side effects, there can be some issues in certain situations, but in the end, we were making the patients better, and certainly the gut microbiome. You know, there's the patients. A lot of patients are getting immunotherapy all over the place, Keytruda, Opdivo, all that, but nobody's talking about the gut microbiome, and we know that's essential. I
Right.
mean, they show that antibiotics at the wrong time will mess up responses. In those situations, maybe you need to consider, fecal transplant. They do have like Rebiota is
Right.
FDA approved now. I mean, you can use it. Though. Unfortunately, the insurance won't pay for it. So it's going to be expensive, but those are options to try to fix that. We started looking at supplementation to optimize the gut microbiome,
Hmm.
seeing that patients who ingested things like camu did better. Patients who eat navy beans do better. I mean, all these type of things that affecting the gut microbiome. Also avoiding certain, obviously antibiotics will mess up gut microbiome, and then some of the
Right.
artificial sweeteners
Hmm.
mess up the gut microbiome. Some natural sweeteners like stevia can mess up the gut microbiome. So there's there anything that disrupts the gut microbiome, we look at that as a potential problem.
Right.
And then we look at like supplements, like what supplements can enhance for the patients. And then off-label drugs. I mean, there's also a lot of medications that are used for other purposes that can be helpful in the cancer patients, and some of those are very cost effective.
Mm.
A lot of these are older generic drugs that 10, 20, $30 a month, but can
Right.
make a big difference.
Yeah, no, that's really interesting. And you guys talk about repurposing some of these drugs that have been around for
Yeah.
quite a while. So, about half of our audience are physicians, and so a lot of them are going to be dialed in on the fact that, oh wait, patient's got a lump. Maybe I shouldn't play with it. Maybe I should just get this thing, biopsied and treated right then and there.
Right.
Um, so if somebody wants to get them over to you,
Yeah.
you're in Beverly Hills, and
I have an office in Beverly Hills. We're operating a lot out of Cabo San Lucas, Mexico. We also have facility in Mexico City. We're also in Miami.
okay.
Then we have clinical trials, and we have clinical trial sites at various places in the country, several in Pennsylvania, and there's others coming online, and we're trying to get more and more out. So, but yeah, through our Williams Cancer Institute website, they can contact us, and we could try to get them in the appropriate place.
Mhm.
For patients, a lot of times if they can qualify for a trial, obviously that's a good option because it's free.
Right.
Um,
Right.
but so there are certain situations that we treat the patients outside the trials, but there can be costs involved in those.
Well, is there some that you have to do out of the U.S. because of just FDA issues and whatnot, or?
Yeah, I mean, so one, I'll be honest with you, I live more actually in Cabo San Lucas, Mexico. Just I like it here a lot. We do a lot of clinical trials here in Mexico. We have a
Right.
great hospital here. Then we have all our setup. So the other thing, yeah, we have a little more freedom on the drugs that we could use.
Mhm.
And trying to do the same thing in the U.S. would just be a lot more expensive.
Right.
I mean, we do it, we've done it, and we just found that it really was just way more expensive for less results for the patients right now. I mean, we're trying to change that. Hopefully trying to get insurance coverage and things like that. But I think to treat some of the patients, it'd be limited. What you could do there. I mean,
Right.
we have a lot more options of immunotherapy outside the U.S.
Yeah, that's kind of, the story for all of a lot of the regenerative, the,
Yeah.
stem cell,
Yeah.
issues. People are having to go to, south of the border, so to speak, and get
Yeah.
some of these treatments and everything. So, I have to ask you a question. I'm seeing a lot of stuff pop up about intracellular parasites. Is that even real, or what's your take on
No,
that?
I don't know. I mean, so I don't know how, I mean, it may be real and maybe it's the issue, but All I know is on our side, we're finding with the right combination of immunotherapy, you know, we're seeing really good results. We're seeing some interesting stuff. I mean, so one thing is, blocking TGF beta, blocking interleukin 1, and we're seeing these cancers just all respond. And so I don't know of the origin. It could be many origins, right? If there's an intracellular parasite
Right.
or other things like that. But I think that this technique is causing the immune system to be strong enough to fight any of those off and get rid of those cancers. The other thing that's interesting is that we do see that cancer and aging are sort of a similar disease and senescent cells and things like that. And
Right.
so we actually find that with these immunotherapies that the patients are becoming younger.
Really?
I know that sounds crazy, but it's
So,
true.
I mean, are you able to document that via DNA
We,
methylation
we
or
are working
telomeres?
on that. Yeah, we're
Yeah.
working on that. That is
Okay.
an area that we're studying right now. So yeah, we're going to do a bigger trial, probably later this year, that we're going to really try to get a handle on the aging effects because cancer ages the cells around it. So I mean, the normal cells around it become older. So if you sample them, and like if you measured, like if you did DNA methylation
Right.
of the fibroblasts around cancer, they would measure to be like 200 years old.
Wow. Okay.
Yeah.
That's
So
that's
the cancer accelerates the aging around it and uses that as a protection mechanism, and that's particularly all the senescence and things like that. So it's producing all these old substances.
wow.
And you kind of see it in the patients that the cancer does age them. But it's interesting that the treatment we see a reversal of aging. So one thing that we've seen and we're trying to document more, but is that the immunotherapy combinations, certain groups of combinations that we give, that the patient's spines are regenerating
Hmm.
and they're regrowing their disc.
Wow.
Yeah,
That's
yeah.
pretty. Yeah.
Yeah.
That,
So that's something we're looking at. So we're gonna do a study looking specifically at spine regeneration with immunotherapy.
that's really interesting. Have you guys looked into any of the bioregulatory peptides that have been Cavison back in the early 70s and at the St. Petersburg Institute were treating a lot of different conditions. One that was striking to me was that they were able to restore some of the the retina, and with scans, and basically they found that it either down regulated or up regulated the DNA methylation, and it was
Yeah.
just kind of interesting. You know,
There's definitely some interesting peptide therapy. There's so much stuff. There's so much stuff that you could do, and
right,
there's some other drugs that, I mean, there's some stuff wouldn't be quite like peptides, but things that are FDA approved, but for other things that do similar type of stuff. But yeah, there's a lot to it. But the one thing that we're kind of finding is that if you get the immune system right, the immune system knows what to do and it fixes you. It makes you better.
yeah,
But that's the thing that we're seeing in the patients, that it's not just that we're getting rid of their cancers, but their gray hairs going away, their the stuff, I mean, the various things that are definitely signs that we're making the patient younger.
what's your thought process on some of these liquid biopsies now?
Yeah, well, I think it's okay, but to try not to disturb the tumor, if you want to make a diagnosis, that's kind of a nice option in a
Right,
way. And so, and then of course, like you know also you can look at like early cancer detection, like Grail Gallery, stuff like that. All those other
right,
things are kind of similar type of stuff. I mean, I think that, yeah, definitely useful. I mean, for me, I know as a radiologist, when I see the scans, I'm like, I kind of know that's cancer. I mean,
right,
I I know that we should be treating this, or in some situations, if there's a question, what we'll do is we'll go in and we'll biopsy and sample, let the pathologist look at it right then,
mm,
and then tell us. And if they say, hey, yeah, this looks like cancer, well, then we're going to go ahead and start treating.
right.
Um, so yeah, but the liquid biopsies, I think for early detection, that's going to be a good option. And then also, the whole body MRIs like the Prenovos are useful as well.
Interesting. What about some of the bloodborne cancers that that you can't really get a tumor?
Yeah. So that's a different area, but we do see some of the immunotherapies that seem to have a response in that area. That's not an area that I deal in with a lot yet. Maybe in the future I'll get over into that, but I've always stayed more in the solid tumors.
Right.
But I do have evidence that some of the immunotherapies that we work with are crossing over and work in the bloodborne cancers, and we may be able to use those across the board.
So you think that that there is a decline now in the amount of chemotherapy, and people are going more into the immunotherapy, or what's the pulse on that?
Well, there's certainly a lot of combo chemo immuno as well,
right?
Which in certain cases could be appropriate, but I think most cancer patients should be offered the opportunity of immunotherapy. It's just unfortunate that your standard immunotherapies are very limited, and so to try to get those to work is much harder. You really need a little more broad base, but there's several new drugs probably on the horizon to get approval, and so options are going to expand soon.
So I have to ask you, as a surgeon that likes to talk about intraoperative or perioperative management, it seems like you guys have really, I mean, what is the I don't want to call it operative, what's the peri procedure? The patient would come in, you've identified the lesion, you're able to get to almost anything anywhere in the body with your imaging. And so is there some that you have to go with CT versus ultrasound? Give me an idea on that, how you go through that process.
Yeah, so the majority of the lesions we do CT, sometimes we do ultrasound, sometimes we do a mix, and we do both CT and ultrasound. Theoretically could use other technology like MRI, you could, but that's easier for us using CT and ultrasound. We can get to most things on that. I would say that part of our group, but I don't deal directly in this, they're actually even doing brain tumors now.
Wow.
With this technology. So, going like basically minimally invasive, and they're using robots and things like that to do that. And I think in the future for us as well, it'll be robotically guided. But right now, we just can do it easily with our. So we triangulate and get get the coordinates and get in there, and we can see it, and we can do imaging, and ultrasound gives you real time. CT you could do real time, but that's more radiation. You're always trying to cut your radiation dose down.
Right.
So, but yeah, I mean we can get about anywhere, and it's really that. Yeah.
So what about when the patient is undergoing this? Are you sedating them?
We don't usually use general. We usually use like a propofol. We use like a MAC.
Right.
We find that's better. I mean, we do look a lot of times at the aspects of anesthesia and the immune response, right? So, I think heavier anesthesia is more immune suppressive, and we want to try to keep things lighter. And we found certain things and obviously like stuff like Tylenol, we know messes up the immune response. Can't give Tylenol.
Right.
And on the anesthetic side, ketamine was actually more immune stimulating than some of the other agents. And propofol seems to be okay, but there's lots of aspects that we've looked at in this.
So I think if you're trying to triangulate a lesion, sometimes in surgery you have to subordinate things, right? I mean, you can't have that patient just wiggling around and you're trying to get a delicate needle placement. You have to have them, so.
But with propofol, still with the patient breathing on their own, but they're out there. We're generally fine. Yeah. If we needed to, in certain situations that we can use like, a little more deep sedation, we could use a laryngeal mask airway or something like that. If we needed to control the airway. I mean, we do it in a full service hospital. We're all prepared for anything, but yeah, propofol for the most part works quite well for us.
That's fantastic. I think that you've answered many of my questions. I'm so astounded with what you guys are doing, and I really appreciate you coming on. Just before we jump off, I want to let everybody know that you guys have some really great YouTube videos that people can go and look at. And then tell them how to reach out to you again at the Williams Cancer Center.
Yeah. So probably best through our website, williamscancerinstitute.com, and they'll have contact information on there, phone numbers, probably email and all that. But yeah, and they can get us through that.
Very good. Dr. Jason Williams, thanks so much for what you're doing, because I think it is going to, I mean, it's already had a great ripple effect. I think it's going to be, tremendously disruptive to the mainstream in a very positive way. And I want to congratulate you for all the hard work and basically probably a lot of arrows that have been shot into your back along the way. So,
it was rough for a while, but now things are better. It's so funny because like years ago, everybody was like, "Oh, that guy's crazy," and now everybody wants to work with me. So it's changed.
Yeah, it's funny how, the only thing is you need like a 200-year life expectancy so that you can really get it, get through that hurdle sometimes. But
we think we might be able to achieve that now with these immunotherapies. That's the thing, is it may be possible.
Well, now people are going to be calling you up going, "Hey, I don't really have cancer, but can you give me some of that stuff? It sounds better than, rapamycin or something."
Yeah, it is better on that. We're working on it. Yeah, we have projects, and we have research projects simultaneously going on with David Sinclair at Harvard. Studying the same drugs that we're working on. So yeah, it's really interesting. We want to see what it may do for longevity as well.
Well, just the fact that you're able to give a person maybe more years of life without taking their quality of life away is such a huge thing. I mean, I had one of my best friends passed away from mesothelioma about a year and a half ago. And I mean, the stuff that he went through the last 2-3 years of his life was like, I don't know how he did it. I mean, and it certainly was not a quality of life.
Yeah, that's the thing, is that, we need to be able to treat cancer patients, but we need to do it in a way where it's, they're not losing body parts. They're not damaged, where, they get cancer, you make them better, but they're still whole. They're still the same. And that they go on and live their life and they don't have a reminder for the rest of their life that they had cancer.
Yeah. Yeah. No, I mean, there's quality and quantity for sure. So thanks so much for coming on. I really appreciate you.
I appreciate it too.